Welcome to all of you. So let's get started.
Thank you.
So our first question, we look at the history of healthcare and healthcare today, and we know that inequalities exist. Let's start talking specifically about these inequalities as it pertains to race. Dr. Brawley, would you like to start?
Yeah, most of the disparities we focus on are in treatment, but we need to think about prevention, screening, diagnosis, as well as treatment. In the case of breast cancer, and by the way, I'm a little uncomfortable with the phrase Black breast cancer because number one, there's 6 states in the United States where there's no Black-white difference in breast cancer mortality. We have to argue that the biology of the Black women in those 6 states is different from the rest of the country if there's Black breast cancer. It is true that about 24% of Black women have triple negative disease and 12% of white women have triple negative disease. But when we look at the disparities in treatment, it's the non-triple negative where the treatment differences actually become a real problem and cause more Black deaths. And even amongst white women, you know, we've actually recently looked at the 40,000 or so women who die from cancer every year. And about 8,000 to 10,000 of those deaths are preventable. Treatment problems are much, much more an issue than screening problems. When I say treatment problems, it's not getting chemotherapy on a regular basis. It's not getting the radiation therapy completed. It's the quality of the surgery. And these are socioeconomic issues. Being Black does matter for breast cancer, socioeconomically more so than biologically.
Thank you. Thank you. Dr. Gary, would you like to also address inequalities as it pertains to race?
Absolutely. I think that we know there is a historical basis that really predates our arrival on this continent, that in that medicine had been weaponized and used as a tool to establish and maintain supremacy. The medical establishment was not created to promote wellness amongst Black and brown people. Although I will say that significant progress has been made in that regard, much of what we see with respect to the resistance among Black women to embracing some of the therapies, as Dr. Brawley mentioned, remains a major barrier, I think, to some equity and some parity. I think that we know that the social determinants of health, the socioeconomic status, the access to care, the utilization of preventive care, all are additional barriers that really create the perfect storm that makes it synonymous with what we say when we mean Black breast cancer. It has, I think, much more to do with those social determinants and the socioeconomic status and the parity as a result of all of those things. But I think that it will be interesting as we engage more in the genomic research and the genetic research to see if there are differences in why Black and brown women tend to develop more of the basal type or the triple negative breast cancers, when in fact they don't tend to have hereditary mutations at a different rate, for example. So, you know, there's a lot more to do and a lot of work, I think, for us to do to begin to catch up on some of those inequities, but they certainly do exist, and admitting it is really a first step for many physicians, many organizations, many researchers, that there is a problem, there is a distinction, and there is an imbalance.
May I just add to that?
Sure.
You know, when we talk about prevention, for example, and social factors that lead to various types of breast cancer, one thing that we've learned in the epidemiologic world is women who have children after the age of 30 or don't have children at all are at higher risk for estrogen receptor positive breast cancer. We've also learned that women who have children at an earlier age who don't breastfeed are at higher risk for estrogen receptor negative disease. I'm actually concerned that in the 1960s, 70s, and 80s, when I was in medical school even, we used to send women home with a case of breast formula, especially in the county hospitals. We encourage Black women who had children not to breastfeed. Now we know that increases risk of triple negative breast cancer.
Mm.
It's not being Black that causes triple negative breast cancer. It's not breastfeeding.
Yeah. So something I want to, as I get ready to ask a question of Stephanie, because you talked about some differences between rural areas, and Dr. Gary also mentioned the social determinants of health. Stephanie, to you, what has your experience been like being a Black woman living with metastatic breast cancer in a rural community? Differences in access or treatment or opportunities for clinical trials. What has been your experience?
I'm going to draw just basically on my experience just from the time that I've lived in a rural area, maybe 3 or 4 years, and what I see here as an advocate now. Access to care is really difficult. You know, you're talking about just basic transportation. The town that I live in, I'm fortunate enough to have a cancer center 5 minutes down the street from me, along with the hospital. But there's patients that live far out in this county that don't have transportation, that have cancer, that can't come get their treatments. They'll get a treatment 1 month, skip another month. They don't have anybody to bring them. They don't have the money to pay somebody to bring them. So getting their cancer treatment is really different. Screening is another thing. There's all kinds of organizations that come into this county to screen women, Black women, for mammography, but there's no follow-up. So there's no entry point per se, an easy entry point for these women after they have the mammograms done to follow up with their care. So if they find something, they run a risk of deciding, do I want to explore it when I have no insurance or little insurance, or do I want to pay my bills for the month? So along with that, you have medical literacy also is a big issue of not knowing. Just plain the education level here, lack of education is another big issue. Women don't we as Black women always take care of the family. We put ourselves last. So, you know, there are several women that I've met that have had a lump in their breast for 2 or 3 years before they decide to go figure to get it out, because by now I've seen it in the ER as a nurse where that mass in their breast has eroded to the outside of their breast. So that's when they decide to go get something done. And we all know that are metastatic, well, you know, you got met someplace else if it's that bad onto the skin. So I have learned just in 2018, how to advocate for myself, even though I was diagnosed in 2015. I knew nothing. I wasn't talked to about clinical trials. I did not have a clinical navigator. And part of that was the oncologist that I chose in Louisiana was a personal friend of mine. So it's kind of like, you know, I guess he kind of figured that I didn't need someone to steer me through other than like chemo school and radiation information when I had radiation. But I didn't know anything. And LBBC, actually, I went to their very first conference in 2018, like a deer in a headlight. I had no idea that there were other Black women that had metastatic breast cancer like me. Nobody that had that many women, first of all, that had metastatic breast cancer. So, you know, and that's what I want to do for my community. Into rural communities, we need to get the knowledge out there to women, to educate them, to know their own bodies, to go with those gut feelings. If they know something that is wrong, you know, it's wrong. Keep knocking on the doors. You know, I've fired several doctors, you know, like I told one the other day, if it weren't for me, you would be in a different field. If it weren't for people like me that had, you know, the misfortune of having cancer. But keep knocking on those doors, pound on those doors until you get what you need. And even in rural communities, I tell everybody here, everybody knows me, hey, Stephanie on the street, if you need something, I'll do my best to be there and educate you. I'll find the information for you. I'll go with you. I have gone to doctor appointments to break it down so they understand it. And, you know, physicians appreciate that as well. So, you know, we just have to realize that we in rural communities don't have all of those therapies that everyone else has. You know, this little cancer center doesn't have a dietitian or social worker or, you know, massage therapy and all of that. So just trying to bring the information to out here into the rural areas.
Thank you so much. As I hear from all three of you, I think you guys have all highlighted a couple of main issues as I get ready to pose this next question to you. Questions of access, questions of timing, questions of health literacy and knowledge. And with that in mind, according to the American Cancer Society, Black women are at a 40% more likely chance to die from breast cancer. In relationship to that, with hearing that term, Black breast cancer, how does that disproportional survival rate in breast cancer connect to that term, Black breast cancer? Can it be an educational point of beginning a conversation? Can you each, any of you, speak to that?
Well, I'll start and then let Dr. Gary add on. Again, let me point out what I said. And by the way, I was chief medical officer of the American Cancer Society when that was published.
Excellent.
There are 6 states where the Black death rate and the white death rate are virtually the same. The question is, what's the difference between Black women in those states and Black women in other states? Now the answer, and by the way, white women in many of the other states don't do as well as the white women in those states where Black women do very well. So the answer really does revolve around getting good, adequate treatment to everybody. Now, unfortunately, there's some women who have breast cancer that we are not going to be able to save, no matter how good the therapy. And I say that because I take care of patients and I have folks who say, I did everything I was supposed to do. Why did this happen to me? Mm-hmm. And no one has an answer except we're not good enough to save everybody. But we can save more and fixing the problems in treatment. Some of the problems in treatment are heavily related with lack of transportation and socioeconomic things like that. Some of the problems in treatment are heavily related to lack of insurance and lack of being able to afford therapies. Some of the problems in transportation are related to bad doctors and bad hospitals. They're all problems that we need to be working on.
Excellent.
I would agree with that to the extent that it truly is multifactorial. And for all the women who are putting into the chat that they breastfed and they still got diagnosed with breast cancer, you know, the preventable and non-preventable risk factors for breast cancer, there are lists of them, and we can certainly put them in the chat. And looking at the extent to which certain things, certain risk factors outweigh others, and how all of it contributes to sort of the perfect environment in the body for cancer to develop is it is a complicated process. And so breastfeeding in and of itself is not a panacea. It is not the sole determinant of prevention. It is not even the most significant preventive thing that you can do. And it's important to note that it is one of many important things, you know, but it is certainly not it's not the holy grail of what prevents breast cancer.
Thank you for saying that.
Sure, and it's not again the greatest determinant of. So I think that there are opportunities still though within research, because when you look at what we knew, for example, about vitamin D and the assay that we used, even as early as recent as 2016, I think, to determine, you know, how we measure blood levels of vitamin D. We found that Black and brown people were consistently diagnosed as having deficient levels, but having increased bone density, and that there's actually a missing binding protein that the test tests for. And so the test itself was faulty. And so when you look at that, the possibility that those things can happen, I think there's room for molecular studies. I think there's room for genomic research. I think there is room to look at what's happened across the diaspora and how Black and brown people came here today, and then the epigenetic, as we call it, the factors that influence the gene changes. You know, are there some influences? when you look at how stress manifests in our body and the historical stress that Black and brown people carry. I think there's some room to say, you know, our hypertension, our stress, our diabetes, our risk factors are perhaps enhanced as a result of even just systemic racism. And the amount of stress on the body to influence disease certainly should not be understated as well, although it might be hard to measure. So I think it's multifactorial, and we don't need to hang our hat on just breastfeeding. But when I hear the term Black breast cancer, I wish I could uncouple those three words, you know, because it surrounds the diagnosis, the morbidity, the mortality, the resources, and it's this perfect storm of all of that. So systemic racism, decreased health literacy that makes us say, well, I don't want to get a mammogram because of radiation, or I don't want chemotherapy because it's toxins, and I don't want radiation, and I don't want certain things, and the conditioning that we then teach our family about, even preventive practices that we don't pursue, and how doctors treat us as a result of that, and why they maybe don't invite us to participate in clinical trials because they are paternalistic and think that we will not accept participation in those trials. And it's this nasty, vicious cycle of inequity that it's a label, you know, and it has been historically a stain, I think, on the coat of white clinicians, on the white coat, right? It's a stain on that white coat, but I see it becoming more and more transforming into a war cry. I see the term Black breast cancer becoming a mystery worth solving, becoming something worth investing into, a moral and a medical imperative. And I think that those are all positive things that are happening as a result of that term.
Celeste, can I just say, Dr. Gary, I think, would agree with me on this. We're talking to a lot of women who have breast cancer. What they can do for themselves is try to make sure that they are getting optimal care. When I talk about Black women not getting optimal care, you know, the paper that made me famous 20 some odd years ago was a paper I published to show that 6.5% of Black women in metropolitan Atlanta who were diagnosed with breast cancer got no treatment. We're not talking about the surgeon didn't take out the whole tumor. We're not talking about they didn't get the chemotherapy dose, or they didn't get all the chemotherapy or the radiation. They got no treatment. Okay. Women who have breast cancer need to have a good relationship with their doctors, need to talk, and the nurses, and because they're going to learn a lot from the nurses. Talk about what's going on in their bodies, what their treatment plan is, get second opinions, and get very literate in what's going on in terms of treatment.
Yes.
But that part, what I have to say, if you don't mind, I'm sorry, Celeste.
No, I was going to throw it to you. So excellent, great. As a nurse,
no, you don't know what you don't know.
Oh, I agree.
Like, you know, where I live, for an example, there's a lady that didn't know that she could go talk to someone about getting a lymphedema sleeve for her arm that was grossly huge. She didn't know, no one had told her, but the doctor tried to explain it to her, but not in terms that she understood. So she didn't know what follow-up questions to ask. And that's part of what I see is women don't know how to ask. They don't know what to ask. And they feel like sometimes they don't have a right to question you as a physician. And I guess being a nurse 40 years or grew up with the mom that way, you know, I'm going to ask, you know, you may not like it, but I'm going to ask that question. But there are Black women that don't feel like they have the right to ask, and they don't know what to ask.
And I think that's a shame. And that's the reason I support breast cancer organizations and women coming together and learning things, and folks like Celeste who can teach them.
And we have a couple of questions from the audience that speak to this. Well, could the disparities that we're seeing be part of structural racism and unconscious bias that contribute to equitable care in treatment? And how can we help our patients through forums like this and talking to other women and their partners? How can we help people learn how to advocate better for themselves?
Dr.
Have
Carey?
an advocate in med school. That's what I say. I mean, have a Black woman or a Black person in med school. Start there. You got to start somewhere.
Wow. I
I've
think
had some that, I mean, and it's not everybody, but growing up in the state of West Virginia, I can tell you, going to med schools over there, it's like they don't know. You know, I had somebody to tell me while circumcising a Black child that I was told that Black babies don't feel pain. Excuse me, I got a son. Don't make me hurt you.
Stephanie, that study came out in 2018 that there is
Yes.
a growing
common.
majority of medical students who are still of the belief, and residents as well, that Black people have less pain. Surgical residents were queried and believe that Black skin is thicker somehow than white skin.
It's the
There
IVC.
are beliefs about our appearance that date back to the early 1900s. You know, when you look at the size of our skull, that data was already published, that they thought that because Black skulls look this way and certain skulls look the other way, that it was a sign of an inferior brain, right? And we still see the effects of this to this day. So to the point about what can be done, I think representation matters. We certainly know that there need to be more Black men in medical school. There need to be more Black people. There need to be more residency opportunities. And we need to increase the pipeline of Black and brown doctors, yes, Black and brown researchers. The funding continues to decline, I think, and it is harder and harder to promote tenured professors in research, in basic science, in medicine, and the pull and the attraction for academia is waning for some. And so we know that we need to increase those slots and those opportunities in that mentorship, because that is where a good number of the research studies happen. They don't happen in the community hospitals. They happen in the hallowed halls of academia, where there are no Black and brown folks to stand up outside of Dr. Brawley and his mentees. You know, where are these folks? And there are mechanisms in place. There are, I think, improvements that have been made over the last several decades, but there's still a lot more work to be done there. To the question of how do we get those advocates, I think that it does, I think it gives cancer patients a great deal of meaning to complete your therapy and to take the lessons that you've learned and the questions that you've asked and the knowledge that you have gleaned and now spread and share and help another. That's why you all are on this panel. That's why people are involved in these organizations. And I think it is absolutely the blessing in part of this cancer journey is to be able to help our sisters. And so I think advocacy and education comes from those who have gone before. It comes from organizations coming together to say, okay, you know, we have a sister, and Ricky knows, she texts me every week, I've got a new breastie in Philly, who do you know? How can we connect this person to resources? Being those connectors to reliable resources, to reliable information, I think is very, very important, because there is an issue with health literacy in our community. And so that health literacy is not all going to come from white coats, because as you said, Stephanie, when people get in front of those white coats, you know, as soon as you hear the word cancer, you don't hear much else. Less than 50%, 30% of whatever that doctor says is gone, right?
Yes.
So where do you get your information from? Health literacy.
And those
Health literacy is going to come from your sisters. It's going to come from your church members. It's going to come from your sorority members. It's going to come from stuff you look up online. So making sure you have, reliable resources is very, very, very important. But it's the responsibility of everyone, you know, and it is not the onus or the blame of the patient for what they don't know and for what they don't know to ask. That's the blame of us for not representing our patients as if they were our family members, and not, ensuring that they're getting the adequate care. Yeah, we have some work to do in our health community, in our medical community. But when it comes down to what treatment our sisters, our loved ones, our aunties, our mothers are going to get, we got to sit in those seats, and we have to make sure that our family members are getting what they need at a time when they need it the most.
I agree with that wholeheartedly, but I really encourage women with breast cancer to get involved with breast cancer organizations, with survivors and other folks who have gone through it. That's the way you hold doctors accountable. Now, Ms. Fairley asked, how come we haven't made any progress with Black women? We actually have. The death rate has gone down by 25% since 1990. So the risk of a Black woman dying of breast cancer today is 75% what it was for a Black woman alive of the same age in 1990. For white women, it's gone down by 40%, and that's part of the disparity that we still need to tackle. And
Yes.
again, the way to tackle it is we have good data to show a substantial number of Black women. It's in the neighborhood of 30 to 40% of Black women with breast cancer get less than adequate care. And we need to fix that problem.
Yes. And this is a great conversation. And I'm mindful of time. So I have one question to throw to you that would help us kind of think through what our next steps are as caregivers, as providers, as persons living with disease. Given the things that everyone has shared on the panel so far, what do you see the major challenges that we will face in the next 6 to 12 months within the cancer community? And what can the individuals listening or watching this program do about those things? And let's start with Stephanie this time.
Okay. Oh, Jesus, where do I start? In the next 6 to 12 months, I would hope and pray that the women that are newly diagnosed have reached out to somebody that has had cancer or going through cancer if they don't understand and ask questions. Like everyone knows, I'm open book, ask. Distance is an issue, pick up the phone, call me. But I would surely hope that we've had some more advancements in medicines. Like for me, somebody making new meds for IM Oslodex. My butt hurts. So we need a new one. Research on triple negative. I just wanted the research to be what it was pre-COVID. I want it to be back to where it was, because that's what's going to keep me alive, is research.
I'll jump in here and go next and say, you know, when you look at the effect of the coronavirus on what's happened with cancer screening, you know, 285,000 missed breast and cervical screenings. We're looking at something like 80,000 positive cancer diagnoses that might have been delayed, 36,000 breast cancer diagnoses delayed. Mammograms were down 94% and down 87%, is, I think, by August. Not sure the statistic for October, but I know that in my practice, I'm seeing more advanced disease. And when they finally take a look at this data, and the epidemiologist, Dr. Brawley, you're going to have a lot of work cut out for you when you start to tease out this data, but how many of those missed exams, delayed diagnoses are going to be among Black women? You know, what's going to happen to the already abysmal 4% of Black participation in clinical trials when we start losing funding for those trials? And the trials have been disrupted, and now we're sort of picking up the pieces there to try to start them again. And you think about the funding for communities and those most in need, and that funding is drying up and it's being redirected to the pandemic, you know? And so I think we can't afford to lose ground. So to your question of what can people do, one, get your screenings. Now is the time. It is time to get your colonoscopy, get your mammogram, get your flu shot, get your shingles vax, get your pneumovax, get your CMOS and everything else. All of the things work together. It's not either or, it's and. And I think teaching our community that prevention looks like utilizing our healthcare system to the max, and increasing our nutrition, and having that garden, that herb garden, and those vegetables, and exercising even if we can't get to the gym. It's all of those things. So I think people are going to have to get really creative and serious about how they look at prevention, because our typical ways of doing things, we can't be in community like we want to. There's no Coleman walk. There's no, you know, we're walking by ourselves, right? Here we are in our homes, you know, walking on our treadmills or marching in place trying to raise money for breast cancer, you know, because we can't even gather. And so there will be challenges. I think we need to get creative and do exactly what we're doing here, which is coming together as individual organizations to utilize our collective force, because that is really where we need to go with this. It can't be just one organization, you know, operating on its own. It really has to be an alliance and a coming together.
Excellent, Dr. Brawley.
Yeah, it was just said very well by both Ms. Walker and Dr. Gary. It's going to get far worse because of the coronavirus. And we've already done calculations that by 2030, the coronavirus is going to cost us numerous thousands of lives. And unfortunately, it's going to be disproportionately Blacks versus whites, poor versus rich, because of the only thing I would add to Dr. Gary's discussion about people not getting screened right now, we have people who have cancer who are not getting treated, people who are diagnosed, who are afraid to go into the clinics, or whose clinics have been shut down or have been overrun. I am not optimistic at all.
That's some troubling news. And to piggyback on what everybody has said, I see two trends as an oncology social worker and managing our uninsured women's program, is that due to the millions of Americans who are out of work and losing their health insurance, I fear we are in a situation of what we were pre-ACA, and some concerns about what these final rulings will be on the ACA, as those decisions are scheduled to come out on the Texas Hold'em case sometime in November or December, that we could be in very difficult times in terms of the number of women not having insurance. And a lot of our fundraising opportunities and programs that still exist, talk to a social worker or a patient navigator, there's still funding for those who are uninsured or underinsured and need their breast and cervical cancer screening. There's some even for colorectal screening. Talk to somebody and we can try and help navigate you where you need to go. But with an increased burden on those very limited resources, I worry about additional missed cancers or late diagnosed cancers. So we're moving to our final question of the day. And each of you can give one final thought of summing up what we talked about today, understanding that there are so many things that need to be done. What is one takeaway from each of you that you want people to know from your perspective and experience about what needs to be done to end health disparities? And this time we'll go in reverse order. We'll start with Dr. Brawley.
In order to end true health disparities, we have to focus on prevention of disease, screening, effective diagnosis, and getting people adequate care. And we need to focus on all four of those things. One thing we haven't talked about today is the fact that the second leading cause of cancer is the combination of too many calories, not enough exercise, and obesity. And that gets into prevention of disease. That's also one of the reasons why Black women have a higher death rate, because we have a higher obesity rate. But we need to focus on, and that's a failure of prevention or risk reduction. We need to focus on all of those things in order to overcome disparities. Thank you for mentioning the Affordable Care Act. Papers have already been written. It is saving lives. It's disproportionately saving lives in states that had a Medicaid expansion like Massachusetts versus states that did not, like Mississippi or Alabama.
Absolutely. Dr. Gary, and then we'll end with Stephanie.
Thank you so much. This has really been an engaging and enlightening conversation, and I'm hoping that it's a spark for a lot more. And so when asked what things I want people to take away, first thing I want you to do is I want you to go talk to your families. I want you to know her story, his story, their story, everybody's story, and stop keeping these secrets in families that put us at elevated risk of which we are not even aware. I want people to take advantage of the screening window before the coronavirus ramps back up every place, because it's not there yet, but it is potentially coming, and now is the time to do so. I want people to educate themselves on the screening guidelines, on their personal risk factors, because there are many and they are unique, and you should be aware of yours and working on yours to the best that you can. I want people to watch this and get angry. I want you to get upset. And I want you to get informed and get involved. And what that means, it means number one, voting. Go vote. You vote with your feet. You're voting for healthcare. You're voting for policies that are going to affect cancer care for a long time to come. It looks like getting involved in these communities and these advocacy groups, and not being an observer, but actually doing some of the work to either raise money, to create programming, to make your voices heard. It looks like holding your doctors accountable. you know, finding that voice and getting involved in activism there and advocacy with your healthcare professionals, and then clinical trials. We have got to participate in clinical trials, so we need to educate ourselves about that. So I hope people get angry, get educated, and get involved.
Excellent. And Stephanie, let's end with you.
Well, Dr. Mo just put it all in a nutshell. Advocacy, not only advocating for yourself to make sure that you are getting the quality care, not just care, quality care that you need for your breast cancer. Advocating to your local constituents that, you know, people that, not them, but people that vote for us, that we vote into office. Talk to them about the laws that will help expand Medicaid or access to care. Those need to be done on a federal level. Talk to your state people, talk to your local people, talk to your neighbor, talk about it in church, talk about it at the doctor's office when you're getting your hair done. Well, kind of not, but we're not doing that anymore. But we need to talk about breast cancer. We don't need to have it in the closet anymore. And if you feel that you are not getting the care that you need, advocate. Find somebody that will listen to you.
Excellent. And I have one or two final thoughts. I would say you are not in this fight alone. Reach out to a family member, a friend, somebody in your care team. If it's a little bit difficult to talk to your doctor, talk to the nurse. If you need to talk to the oncology social worker to advocate for you to get a resource that you need, transportation to get back and forth to an appointment, connecting to other outside organizations such as Living Beyond Breast Cancer to get additional education, sharing with family members or friends. You are not in this fight alone. We're going to need continual vigilance, resources, support, that fire to push for additional funding for all individuals and families who are impacted by cancer. So I want to thank everyone who participated in this wonderful conversation and spirited conversation. There was so much to try and get in this time, but I want to thank Dr. Brawley, Dr. Gary, and Stephanie for participating.